Good morning. I'm delighted to be here this morning just to say a few words for 2 or 3 minutes and introduce very special individuals who are our friends, have been a family here with us, and year after year come back to be with us. For those of you who I may not have met, I'm Diane Hupp, have the privilege of serving as the president of UPMC Children's Hospital. I've been here for my career. And today in particular, I think about the last several decades. When we think about what we do here at Children's Hospital and the work we do every day, there's nothing more important than patient safety. This Grand Rounds is dedicated to patient safety. Year after year, we've been doing this for quite a number of years here. I actually remember it's been about 25 years when we started our journey to improving patient safety for our kids and our families here at Children's Hospital. And as healthcare goes through so many changes, when I was thinking about this and how much we've grown, how things have evolved, how care is changing, patient safety has not changed in its core principle. It is so important for every one of us every day, and I'm thrilled to see a variety of individuals here today, from leadership, from the medical leadership, to our nursing leadership, to our pharmacy staff, to administrative staff, our clinicians, nurses, docs. Thank you for being here today. This is an important one. Most important, I have the privilege of introducing to you our special family, Maddie and Michelle Christenson. Many of you have known, but some of you may not know. This is a family for Michelle, who lost her daughter, Izzy, and lost her daughter to a medication error. When we think about that, this is a family that has also turned a horrific tragedy into something positive, into doing their part in improving patient safety in organizations, and in particularly in our organization. When this occurred and after this horrific event and tragedy occurred, Michelle Christenson came forward. Michelle has been instrumental in so many ways here at Children's. She served on our quality committees. She's helped to put an indoor playground at one time here. She has a walk. This is all for awareness on the importance of patient safety. So today, I'm privileged and proud to introduce to you Michelle Christenson, mother of Izzy, and sister Maddie Christenson. If you would please come up. We applaud you. We thank you. And I leave you with a message that I don't forget, that I've heard Michelle say time and time again. And that message is, pay close attention to everything you do, every time, every patient, every encounter, every action. Thank you, Maddie, and thank you, Michelle.
Good morning, everybody. Thank you here for being here bright and early with us today. We really appreciate it and taking the time to talk about patient safety. First, before I even get started, I want to say thank you to all of you, to UPMC, Children's, for continuing the tradition of patient safety, for Patient Safety Week, Isabel's conference, continuing just culture that you guys have brought on with since Isabel's passed. It means more to us than you even realize, and doing this in her memory. And if, like I said, if we can save one life and make a difference, we've done our job. So thank you guys so much. And with that, I'm going to tell you a little bit of a story. Let's put the reading glasses on. My name is Michelle Christenson, and I am the mother of 3 daughters, Maddie, Izzy, and Ari. In 2008, my middle daughter, Isabel, died following a medical error. The conference is named in her honor. Each year, our family is given the chance to stand before you and share a little bit of our story. Talking about Isabel is how we get to celebrate her life. She was spunky, sweet, very opinionated, caring, thoughtful person who loved her family, this hospital, as you'll be able to see by some of the photos, and living life to its fullest. When I sit down to write the speech, it's always a challenge. I want to convey the heartbreak over Izzy's life being tragically cut short following a medical error of an incorrect concentration of IV potassium, and how that error changed our lives forever. But I also want to share with you how Isabel lived her life and how much she meant to everyone who had the chance to know her. So I want to share with you a few quick stories to help capture the essence of Isabel. Isabel and Maddie loved to play dolls. They had a vivid imagination, and their babies were involved with their adventures. From the playroom to the backyard to the hospital, the girls loved to be able to pretend to take care of their babies. In just a few short weeks, actually any day, any week, Maddie and her husband Eric will be welcoming their daughter to this world. Well, it's hard to imagine myself as a grandmother, because I can't be that old to be a grandmother. Over the years, I've watched her pretending to be a mom to her baby dolls and being a second mom to Izzy and Ari. But it makes my heart sad to know that I will never get to watch Isabel as an aunt doting on her niece. I know she would be excited to welcome the baby into the family, and I am confident that she will always be watching over Maddie's daughter. Today, I try to find peace and solace in the belief that until Maddie gives birth, Isabel is holding, rocking, and singing and loving her niece. Till she makes her grand entrance into this world. This year's safety conference is about equity. This was a cause Isabel helped to support when she was alive, as she would volunteer for the free care fund every year to help support, and she would also do support materials and print materials. But I think my favorite story about Isabel was regarding equity came at the transplant games. The transplant games are a variety of athletic competitions held for transplant recipients to participate in a way to demonstrate how much their lives have changed thanks to the generosity of a donor. Izzy was a multivisceral and a kidney transplant recipient. And the games were coming to Pittsburgh. Isabel, like other young kids, were excited to do the 100-yard dash. She was having a few health issues at the time when the games came around, but quitting was not in Isabel's vocabulary at all if you knew her, and she was very stubborn. We ended up agreeing that we would line her up at the start line in her wheelchair. And then halfway through, her dad would meet her with her walker to allow her to finish the race on her own. I remember the girl next to us in the lane complaining that it wasn't fair that someone was going to push her in the race. Everyone assured her it would be okay. And as promised, the fellow competitor finished the race way far before Isabel. But as Isabel made her way down the track toward the loving arms of her sister Maddie, I can promise you no athlete was being cheered as loud as enthusiastically as the whole stadium was rooting for Isabel. This was just her way. She naturally drew others to her and her never give up spirit. Isabel's life was big and full, and how she lived is more important than how she died. But as healthcare professionals, I want to remind you that it was a medical error that caused her death. And this is why every patient, no matter how they look, what problems they have, how many times they've been to this hospital or any hospital, they deserve your attention and detailed care every single time. It breaks my heart to know that Isabel has missed out on so many things in our lives and our family. She is loved, she is missed every single day. You can help honor Izzy's life by helping to make sure that you work hard to prevent medical errors every day for every patient, every single day. At this time, I'm proud to turn over the presentation to my oldest daughter, Isabel's big sister, a nurse, and soon-to-be mom, Maddie Lewandowski.
Hi, everyone. As you've heard a few times, my name's Maddie. I'm Isabel's older sister. For those of you that don't know Isabel or her story, she was born with a mitochondrial disease and pseudoobstruction. During her short life, she required 2 transplants. 2004, she got a stomach, liver, small bowel, pancreas, and duodenum. Then in 2006, she received her kidney. Her transplants were her gift of life, and even at such a young age, she was a strong advocate for the importance of organ donation. But to me, Isabel was my little sister. Izzy was spunky, smart, feisty, caring, and thoughtful. Isabel looked up to me as her big sister, but I looked up to her more importantly. She was and still is an inspiration to me. She always brightened up my day and put a smile on everyone's face that she saw. If you ever had the chance to meet Isabel, she probably had changed your life in some small way. Growing up, Isabel was my best friend and constant playmate. So much of our lives revolved around her health issues, but she loved life and she loved this hospital. Izzy viewed the staff here at Children's as her friends. She loved to have squirt gun fights with the staff on the floor, play nurse at the nurses' station, and make silly faces with all the different men and women like you who work tirelessly to care and help for sick kids. In many ways, Isabel considered the hospital staff to be her closest friends outside of our family, which made the fact that she died following a medical error at this very hospital even more heartbreaking. Even today, all of these years later, it's still hard to put my sister's death and my feelings into words. I struggle to comprehend how a routine medical draw turned into a medical error of giving Izzy a fatal dose of potassium that day. I still cannot comprehend how it happened. I often think about what I or others could have done differently to have prevented her death. So I share Izzy's story with all of you in hopes that it enhances your vigilance and opens your heart to the impact that our medical mistakes can have on everyone. As hospital practitioners, every day it is everyone's responsibility to prevent medical errors like this from happening. Life is so different without Isabel by our side. Sunday's her birthday and she's not here to celebrate with us. Today, all of the most exciting moments in my life also have an element of sadness in them. Isabel's not here to celebrate any of them with us. My younger sister, my husband, and my future daughter will never meet her. They will only know her because of the stories we tell. I know that life goes on and that it's normal for people to move on, but the reality is life didn't go on for Isabel. And so we live every day clinging to the memories of her. I will always wish I could have my sister back. The pain and sadness of missing her will never go away. I know her death has taught me many things in my career as a nurse and in life. And so today, when you leave this conference, please try to remember that it's not just a medical error that you're working to prevent. It is a lifetime of small, everyday moments like smiles, laughs, and secrets shared between sisters that can never be replaced. We all entered the healthcare field because we have a compassionate desire to help others. And there is no doubt that you make a difference in what you do every day. But we ask you to never be satisfied, never grow complacent, and always strive to pay attention to the details, because your one mistake could change someone's life forever. Thank you.
Thank you, Maddie and Michelle, for sharing Izzy's story with us. And I especially want to express my gratitude to the Christenson family for your continued support of this Grand Rounds and all that you do to support our patient safety and quality work here at UPMC Children's, and especially Michelle and Maddie for sharing Izzy's story. For those of you who may not know me, I'm Andrew Buchert. I'm one of our medical directors here and have the privilege of working closely with so much of our safety and quality work here at UPMC Children's. And I'm honored to have the opportunity to introduce not one, but two nationally recognized leaders in patient safety, quality, and health equity, both who are from right here at UPMC, who will present our Isabel Christenson Memorial Lecture this morning. Our first speaker is Dr. Sylvia Owusu-Ansah. She is an associate professor of pediatrics and emergency medicine, a board-certified pediatrician, pediatric emergency medicine physician, and an emergency medical services physician. She serves as the EMS medical director at UPMC Children's, as well as our associate vice chair of diversity, equity, and inclusion for the Department of Pediatrics. She is a leading national expert on pediatric pre-hospital emergency care and she serves many leadership roles locally, regionally, and nationally, including a federal appointment. She's dedicated to creating positive outcomes for the surrounding community and all the patients that we serve through the lenses of justice and equity. She co-leads a successful neighborhood middle school health careers pathways program, and since 2023, she has taught over 500 people CPR, including community members and Division I athletes. You may have seen her on the news and on various social media in her recent work with this. She also recently received the inaugural Department of Pediatrics Justice, Equity, Diversity, and Inclusion, or JEDI Award. Dr. Owusu-Ansah received her MD degree from the University of Chicago and completed residencies in a residency in pediatrics at Children's National Medical Center, followed by 2 fellowships in both pediatric emergency medicine and emergency medical services at Johns Hopkins. She also earned her MPH in health policy from Johns Hopkins. And our second speaker this morning is Dr. Johanna Vidal-Phelan, who serves as the Chief Medical Officer for Quality in Pediatrics at the UPMC Insurance Services Division, as well as a clinical assistant professor of pediatrics here at the University of Pittsburgh School of Medicine. Dr. Vidal-Phelan completed her Doctor of Medicine from the Robert Wood Johnson Medical School in New Jersey, where she was awarded the Sidney Sussman MD Award for Academic Excellence in Pediatrics. She then completed her general pediatrics internship and residency at the University of Washington and Seattle Children's Hospital, as well as a healthcare-focused master's in business administration from the George Washington University School of Business. In 2022, Dr. Vidal-Phelan graduated from the America's Health Insurance Plans, or AHIP, Executive Leadership Program, earning the distinction of Certified Healthcare Insurance Executive. Dr. Vidal-Phelan has over 20 years of experience in clinical practice and has been a thought leader in the fields of value-based care, population health, care management, and social determinants of health. She's an active member of the Board of Directors of the Greater Pittsburgh American Heart Association, a fellow of the College of Physicians of Philadelphia, and a member of the American Academy of Pediatrics, American Medical Association, and the Pennsylvania Medical Society. This fall, Dr. Vidal-Phelan joined the board for the Alliance of Community Health Plans. For her advocacy work during the COVID-19 pandemic, she was awarded the Aldea Top Doctor Award in January of 21, as well as the 2022 YWCA Heroin Award. Dr. Vidal-Phelan provides pediatric primary care in the Division of General Academic Pediatrics Primary Care Center, and some of you may have worked with her in that center. And she also is a frequent invited Becker speaker amongst numerous other national speaking engagements. Thank you both for sharing your expertise with us today, and I'm going to turn it over to Dr. Owusu-Ansah.
Good morning, everyone.
Good morning.
Thank you for coming here at this early hour. So honored to be here with the Christenson family. Watching Izzy's story, I'm trying not to cry. I'm reminded of the work that we do and why we do it. At the same time, I'm very grateful for the stories and the lives. And so thank you. I'm also grateful to Dr. Buchert for inviting us to come speak today. Thank you. And then, just echoing, that's fine. We'll try to get through this. And I'm honored to do this in conjunction with Dr. Vidal-Phelan. So with no further ado, all right, thank you. I think we're good now. Whew. I'll just want to say one more time, I am grateful to the Christenson family. Thank you. Thank you. All right. So you heard my intro. I don't need to hopefully introduce myself today. I'm very excited to be able to talk to you about patient safety with the health equity lens. All right. So some of our objectives for today are to talk about the importance of patient safety and go over some of our patient safety definitions. Then we're going to describe the unique aspects of pediatric patient safety, which is a little bit different than when we think about adults. We're going to describe health disparities in patient safety. And then guess what? We're going to bring the two together and talk about health disparities in pediatric patient safety. And then no lecture would be complete without talking about the solutions, right? We all know what the problems are, but the key to healthcare treatment and management is finding those solutions and being a part of the solution team. So excited to talk about that today. All right, so the importance of patient safety and quality improvement, according to the World Health Organization. So patient safety is the most critical reason why quality improvement is necessary in healthcare. And I think Miss Diane Hupp said that earlier. And so then we ask ourselves, what is quality improvement? And quality improvement aims to reduce the risk of adverse events, which includes medical errors, injuries, and infections. So what is an adverse event? So an adverse event is an injury caused by medical management rather than the underlying disease. So next we'll take a look at the landscape of what this means. What is the scope of this? What are we talking about? So according to the World Health Organization, it's kind of scary statistics that are out there. In the United States, anywhere from 44,000 to 98,000 Americans die in hospitals each year as a result of adverse events. Above 50% of harm is preventable. And that's what we have to hold on to today. And half of the harm is attributed to medications, as we heard in Izzy's story. In a recent systematic review study showed that adverse events affect nearly 1 in 10 patients during hospital stays. So then you may say to yourself, okay, we got to fix the problem within our hospitals. Hold that thought. It's not only within our hospitals that is the problem, but in primary and outpatient healthcare settings as well, we have patient safety issues. And in this space, up to 80% of those can be avoided. Some of the most common adverse events that are avoidable that we deal with today include medication errors, unsafe surgical procedures, healthcare-associated infections, diagnostic errors, patient misidentification, and unsafe blood transfusion and venous thrombolism. And so 4 in 10 patients are harmed in the primary and ambulatory setting. So let's digest some of those statistics. And this wouldn't be, when we talk about healthcare, we also always have to talk about cost. So on a global scale, the indirect cost of harm amounts to trillions of dollars, right? We hear about the deficit in the United States today and how much that is. Imagine if we really put a focus on patient safety, how much we would save and how much more that money could go towards better healthcare in other areas. So obviously an investment in patient safety can prevent harm and lead to significant financial savings. Now we're going to switch gears. Now we're going to talk about the unique aspects of pediatric patient safety. Trillions of dollars. All right. So pediatric safety errors are very unique. We know that at Children's in the way that we work with our children. So we do medication based on weight, right? An adult, most of the medications you can have one dosing. You can prescribe one tablet, 100 milligrams for this or 250 milligrams for that. Most of us have to pull out our calculators or our apps, even if we've been doing this for 5 years or 20 years, to calculate medications. And as you can imagine, especially in my realm, in the pediatric emergency department, where things can be very intense, high acuity, you fumble around with that number, you fumble around with somebody's life. So some of the unique aspects to pediatric safety is the weight-based dosing and nutrition. And so you see here, the campaign is spoons are for soup, milliliters are for medicine. So use your syringe at home so you can best measure for your child and not overdose your child at home. There's unique epidemiology and the conditions require hospitalization. Izzy was an excellent advocate for herself and others. But in the global scale of things, children aren't able to self-check. They need additional advocates. A lot of us adults can advocate for ourselves, but in the way that the Christenson family is advocating for patient safety and other children's lives, we also have to advocate for our pediatric patients. You know, a two-year-old might not be able to advocate for themselves. And there's also limited research and data in pediatric specific issues for all you researchers out there that are looking for a project or an area. This is the area that we really need some help and support in. In addition to that, birth trauma accounts for the highest rate of pediatric adverse events. And all this data is from AHRQ, the Agency of Healthcare Research and Quality, many of you may be familiar with. All right, so again, we're still talking about pediatric safety. So AHRQ does have pediatric quality indicators. There are several patient safety indicators. So in general, the PSIs are your patient safety indicators looking at in-hospital events. And so that's your PSI. But we do have pediatric quality indicators as well. There are 16 indicators that focus on inside the hospital adverse events to children, adolescents, and neonates. And so it's good to know that we have these markers to measure. All right, now we're switching gears to health disparities in patient safety. So not surprisingly, several studies in the United States have pointed toward ethnic differences playing a role in patient safety. Patient et al. Found that Black patients were approximately 20% more likely than white patients to experience a patient safety event. So now we have come at the crossroads of the two, health disparities and patient safety and pediatric patient safety. What have we found there? Well, pediatric safety events are not just indicators of hospital safety, but they carry serious implications of patient health. They are associated with increased lengths of stay, heightened morbidity and mortality rates, and elevated resource utilization. Consequently, these disparities result in not just inequitable healthcare, but note higher burden of health complications among socially disadvantaged groups. This is the data. What does that mean? Not good, right? And when we think about these patients, I think about this pictorial, right? When we think about our socially disadvantaged, marginalized, minoritized patients, you do everything in your power to stay healthy, but the system is stacked against you. And this is what we need to recognize, and this is what we need to change. So here we go. Are you ready? We're going to go through some of these rapid fire healthcare disparities in pediatric safety. 1, there was a study that found that Black and Hispanic pediatric patients treated in hospitals were significantly more likely to experience a number of adverse safety events compared to their white counterparts. So both in adults and pediatric patients. And that was seen in the 2019 Kids Inpatient Database, excuse me. Next, 55% higher odds of postoperative sepsis in Black children. Next, 34% higher odds of postoperative respiratory failure in Hispanic children. Next, this is what gets me every time as a pediatric emergency medicine physician. I want you all to look at this table and let it sink in. 7 times and 2 times higher the death rate for asthma in Black children and Hispanic children. That is a significant problem. Okay, you say, oh, okay, Dr. Owusu, those are national statistics. Well, let's look locally. So our yellow line are Black pediatric patients from the ages of 0 to 17 in the state of Pennsylvania, and our gray line is within our city. And so these are the number of asthma hospitalizations. Need to work on this. We've all heard this news. Systematically reviewed racial and ethnic disparities in pediatric patient safety and found higher rates of newborn birth trauma and infections attributable to negligent medical care. Okay, that's the stats on the national level. Locally, how are we doing? Not great, sorry. So again, the yellow line is for Blacks Black infants in the state of Pennsylvania. And sorry, for the state, Black patients in the state of Pennsylvania. So not doing great. And then when we look at these bars, the Black patients are in orange in Allegheny County. Again, this is quite a while ago, but the stats have not changed that much. All right, then let's talk about insurance. The prevalence of pediatric safety events are significant. And we find that children who are on Medicaid are the most vulnerable of hospitalized patients. But we also recognize that, interestingly enough, we can define this on a race ethnicity basis, because whether you have Medicaid or private insurance, disparities still exist in hospital care. Immigrant patients, in comparison with US-born patients, experience more patient safety events in hospitals. Previous research has suggested that disparities in patient safety exist for Black and Latino children and for children whose families do not primarily speak English. This is us. This is the growing diverse population of Pittsburgh. We have more immigrants coming into Pittsburgh, immigrant populations, I should say, and our Latino population is growing as well. And I'm extremely excited about that. But what we have to recognize with that is that when we provide the hospital care, it needs to be equitable for all of our patients from all the backgrounds. And in summary, what this means is that the Joint Commission says to make healthcare equity a leader-driven effort. So it is an organization's priority to have somebody lead in the activities to improve healthcare equity for the organization's patients. And leading the organization's activities to reduce healthcare disparities may be an individual's primary role, but I would argue that the organization is responsible as well. And if you leave my lecture with nothing else, take this home. Improving health equity for the organization's patients is a quality and safety priority. It is rolled into one. It is not its own separate entity. If you say that you care about quality and safety priority, then you care about health equity. It all goes together. All right. Now I gave you all the humdrum and the problems and the issues. We have solutions, and we have solutions here at UPMC. And so I'm happy about that. Children's Hospital of Pittsburgh. We are very happy to have our fellow neonatologist, Dr. Ogi Fobibi, who is doing a lot of work in the space of infant mortality and working with doulas and research in that space. And so when we talk about infant mortality, things are getting done. So we're going to briefly talk about that. The main focus today, though, is the QI project led by Maria Say Danson, who is here today. So honored to have her share her work with me. The manager at the International Department at the UPMC Children's Hospital Pittsburgh. Her work has also been supported by Dr. Loretta Mateo, who's also here, and Dr. Maya Raghavan, who's not here, in the Office of DEI. So very honored to have her here and to share the wonderful work that she's doing in the space of preferred language documentation. So we're going to go over that. So the mission statement here, again, equity. Ensure that patients and families who are language diverse have meaningful access to the same services, information, and other vital services as everyone else by implementing a program to increase the effectiveness of healthcare communication. I love it. So the first thing Maria did was to say, do we actually have a problem? Is this program worth implementing? Are there disparities in this space? Well, found out, yes, there are, right? So when we look at this graph and we look at readmissions to our hospital, patients who are language diverse are more likely to be readmitted into our hospital than those who speak English alone. So there are some disparities there. And then looking at non-English versus English, 7-day readmission rates and average length of stay, again, you can see the disparities there. Non-English 9%, almost double for readmission than English speaking. Understanding the landscape. So Maria and her team took the time to look at what are the languages that we are the language composition of our patients that we interact with every day here at Children's. As you can see, more than half are Spanish speaking, a significant portion are Arabic speaking, and we have many languages in between. And looking at the statistics, 2.4% of patients discharged in 2022 from CHP are language diverse, and 8.6% seen at GAP were language diverse. And as you can see, our numbers are growing. Maria Say looked at whether there was consistency in documentation, and you can see there's variation based on whether based on age group, based on whether you're talking about the caregiver, the patient, or both documented. So she set out the landscape. She saw that there were disparities there that needed to be addressed. So you'll never get better by focusing on the problems. You'll only get better by focusing on the solutions. So here we go. So moving forward, Maria Say and her team said, we identify the patient and the caregiver's preferred language. We are going to document the preferred language into the patient's medical record. We're going to communicate, write the preferred language on the communication board in the patient's room so that everyone is aware. And then we are going to provide the patient and the givers with I speak cards, which are cards that state the language that the provider is able to speak and the patient is able to speak. And you can see in there, several of the languages are Spanish, Arabic, and it includes ASL. Provide interpretation services when required and use a teach-back method to make sure that everything was understood. All right, so the aim of the project, again, this was a QI project, so they focused on a couple of units within the hospital in an intensive care unit, which was the NICU. So the aim was to increase documentation of language preferences for patients admitted to 2 acute care units, 7B and 7C, and the NICU. The medium-term goals were to increase documentation and language preferences, increase the utilization of the current language resources, increase interpretation services, and increase patient satisfaction. Long-term goals were to document language preference for every patient. There's that word, there's that term, every patient, every time. Every patient, every time. Improve key performance indicators, obtain more funding, and recruit language equity staff. All right, so as part of the project, they did interviews. They found that language preference is communicated verbally, that many consult services come to the floor unaware of language needs. Social work is integral to language access and equity for the 2 units. And another unit might be an opportunity to involve social work. So again, collaborative efforts. In the NICU, current workflow does not allow for easy verification of parents' language preference. And there is frustration among staff with lack of translated discharge documents. All right, so part of the intervention was to provide an educational campaign to encourage the utilization of language resources, such as the I Speak cards, to standardize the process, right? That's how we get to quality improvement, is through standardization. Again, the term that was used earlier, asked for preferred language, every patient, every time, at the time of admission. Designate individuals to act as champions, right? Advocates for language access in the way that social work does on 7B and in the NICU. Cycle 2, ask for language preferences at the patient level, displayed preferred language visible on our electronic medical records. Again, the intervention was the campaign, the standardization process, and changes to the admission history form and language rounds. So more details about the educational campaign. So highlights of the educational campaign. They were able to carry out 12 educational sessions. There were 100 attendees. There were CE credits for it. Food was provided. We all know that's very important if we want to be engaged in some of these projects, right? And then assessment of the survey. Is it important? Is it easy? Know where and when, comfort asking questions, how to modify, and then main suggestions. So education, ensure documentation, separate form, more support for language services, ensure proper documentation in the ED, self-reporting, add language questions to Parlay Q. So Parlay Q, AIQ is a AI service that focuses on rounding techniques and that nurses use on some of our floors to kind of help streamline patient interaction and rounding techniques on the floors, if people aren't familiar with that. So when we talk about the process standardization, some of the highlights were script developed with community and staff feedback. Now that is important. A lot of what we do, we focus on what is behind these four walls in the hospital. But I think it's really important to get community engagement, get the engagement of the community and the patients that you serve in any project that you're doing related to patient safety. Script and instructions included in the mission form, and these are some of the examples. I would like to talk about language with you because we provide free and confidential language interpretation services. And key here, what language would you like to speak with your doctor and nurse? We ask these types of questions for other equity issues, but it's important here to ask for preference. They also perform language rounds during the implementation. So 57 rounds were accomplished between January and April of 2023. Pretty impressive. And the measures looked at consistency of documentation, was preferred language asked at admission, utilization of language services, language resources. Did we put the language preference on the board? Did we use our I Speak cards? Were language services provided? And then accuracy of documentation. What was your preferred language for health communication? All right, so just a reminder of this beautiful QI that was done. Identifying patients' preferred language, documenting it, communicating it, and having the I Speak cards. So we said we're working on the solutions, and what do we think happened after the intervention? Things got better, things got worse? Any guesses? I guess I wouldn't be here if things got worse. Yay, things got better, right? So we see there after the intervention, we're looking at consistency of language documentation, our graph went up. So congratulations, Maria Say had to step out, but congratulations to her and her team for the work that they were doing. So here are some quickly next steps. Continue education efforts in a structured way, work to improve accuracy of documentation by including language questions and leader rounds, reviewing the process to ask for patients' language preference when they're not present at admission, exploring ways to facilitate self-reporting language preference, continuing analysis of the reports, designating individuals as language champions. I love this because as pediatricians and as people who take care of kids, we are naturally advocates. And ensure that language preference is placed in a permanent and visible place in the electronic medical record. So this is Maria Say's team. I want to leave you with this. Let us rise. Let us recognize, identify solutions, and examine. And again, like I said, if you take away anything else, improving healthcare equity for the organization's patients is a quality and safety priority. Thank you.
Thank you, Dr. Sylvia, Dr. Andrew, the Christenson family and children's. I am deeply grateful for the opportunity to present at today's Pediatric Grand Rounds. It is an honor to share with you this presentation titled, Equity-Driven Quality Care, Becoming Part of the Solution for Health Equity. The learning objectives for today's presentation are to understand the concepts of health equity and health equity, to recognize how differences in health outcomes exist across various populations due to social, economic, and environmental factors, to explore how disparities extend beyond medical care and affect overall well-being, to comprehend how addressing disparities influences patient satisfaction, outcomes, and overall quality. My hope is that each one of you today will leave today's presentation with a renewed commitment to be advocates for achieving health equity. I would like to start my presentation with a quote from Martin Luther King Jr. Of all forms of inequality, injustice in health is the most shocking and inhuman. And I want to share with you a case presentation. This is a real patient. This is one of my patients, and I was a pediatrician in this case. A 30-month-old patient arrives at my office for routine well child visit.
When I asked the parent what brought them to the office today, the mom shared that she was there because the child was starting daycare and needed a form filled. And prior to walking into the patient's room, I reviewed the patient's record, and I noticed that the patient has 6 emergency rooms in the last 12 months. I also noted that the patient had missed a well-child visit and was behind immunizations. As we progress in today's presentation, I want you to keep this scenario in mind and think of what additional information you would like to ask this patient and parent as part of the visit. Now, let's discuss some basic definitions. What is health disparities or health inequalities? Health disparities or health inequalities refer to potential preventable systematic health differences that negatively impact economically or socially disadvantaged groups. Inequalities in healthcare are avoidable, they are unnecessary, and they are unfair. And this diagram demonstrates that when health disparities are identified, they should drive actions to achieving health equity. Health equity serves as a fundamental principle that drives efforts to eradicate health disparities or inequalities. Health disparities has many dimensions that include race, gender, socioeconomic status, level of education, sometimes religion, geography, sometimes an accent, and they originate from longstanding inequalities. Efforts to address disparities must be part of a broader endeavor to transform healthcare. And these efforts need to focus on improving the quality of care delivered to all our patients. Addressing health disparities requires that we recognize them. That's the first step. And then that we commit to reducing them. And not forgetting that we need to emphasize the patient and the family dignity and empowerment. This is a diagram from the Unequal Treatment Confronting Racial and Ethnic Disparities in Healthcare report that was published in 2003. And this diagram demonstrates visually how quality of healthcare, which you're going to see on the y-axis, is different among non-minority and minority patients. Although care can be different because of clinical appropriateness and need and patient preferences, what is not okay is that disparities experienced by minority communities are caused by discrimination, biases, stereotype, and others reasons. There are many barriers to addressing health disparities. And when I ask clinicians, what is our responsibility in addressing them? I often hear two extremes. In one end, I hear hopelessness. There's nothing I can do about it. On the other one, I hear lack of ownership. This is a social problem to be addressed by the government, by society, by others, not healthcare professionals. I believe that it is our responsibility to follow through and address social determinants of health and achieve health equity with the same energy and expertise that we devote to the clinical aspects of care we all provide. Equality is not the same thing as equity. This diagram is a powerful depiction of the difference between equality and equity. Equal distribution of resources, the same number of crates in this scenario, to every individual in a community does not translate to the delivery of fair and non-discriminatory aid. It is only by adjusting for the individualized needs of the community and resourcing a different number of crates to each person based on the personal status can disparities in the access to resources within a group be eliminated. Equality does not acknowledge the possibility that a community is composed of a mixed population of more and less advantaged members. The shortest person in the illustration only has equal opportunity when resources are distributed equitably, not equally. So what is health equity? According to the Robert Wood Johnson Foundation, health equity means that everyone has a fair and just opportunity to be healthy as possible. And discrimination is a social action that is unfair and that causes harm to certain individuals or groups. Let me explain. This is a map of Erie, Pennsylvania that illustrates life expectancy by census tract. As you can look at the map, focus on the central yellow ovals demonstrating the life expectancy of two adjacent census tracts that differ by 20 years. How is this possible? Have you ever heard of redlining? In the 1930s, the federal government created redlining maps for almost every major American city. Redlining was the practice of denying access to mortgages, not only to individuals, but to whole communities. Between 1935 and 1940, an agency of the federal government called the House Owners Loans Corporation graded the residential security of thousands of American neighborhoods. And by security, they meant the relative security or riskiness of the banks, saving loans, and other lenders who made the mortgages. The practice of redlining led to racial residential segregation, which is the primary factor contributing to the racial and ethnic disparities that we see today. Racial segregation and neighborhood deprivation are associated with poor health outcomes. A reality is that here in America, health and well-being are, to a large extent, determined by your race, by your ethnicity, by your income, by your immigration status, and where you live. In medicine, how long have we recognized that health disparities impact quality of care and outcomes? Not until recently. After years of observing poor health for Blacks and other minorities groups, Margaret Heckler, who was the Secretary of Health and Human Services in 1985, commissioned a task force. The task force report on Black and minority health was released in 1985, making this the first time the federal government provided this type of analysis. The Heckler report found that in the United States, 60,000 deaths occurred each year due to health disparities. And as a result, in the 1986, the Office of Minority Health was established. Two sentinel reports to note are the Crossing the Quality Chasm in 2001, who identify equity as the key component of quality, and the 2003 Unequal Treatment Confronting Racial and Ethnic Disparities in Healthcare. They were both published by the Institute of Medicine. And this report confirmed that racial and ethnic disparities in health exist. And because they're associated with worse outcomes in many cases, they are unacceptable. Many of the recommendations from the 2003 report are still recommendations we can implement and use today. But it was 2020 when health disparities became a focus in our national healthcare agenda, thanks to two crucial events. One was the COVID-19 pandemic, and the other one happened in May 25th, 2020, the murder of George Floyd. These events highlighted the effect of historical and structural racism, the role of social determinants of health and disparities in health and in healthcare. Now let's come back to Pittsburgh. I'm going to share with you the story of two birthing parents who identify themselves as female, and from now on, I will refer them as mothers. Mother in orange, mother in purple. Both are 27 years old, both have Gravida 2 Para 1. They both deliver a McGee. Actually, the rooms are next to each other. Mom in orange gave birth to a baby that was 7 pounds, 3 ounces. Both delivered a spontaneous vaginal delivery. And mom in purple had a baby that was 6 pounds, 8 ounces. Mom in orange lived in zip code 15217, which is Square Hill. Mom in purple lives in 15221, which is in Wilkinsburg. These two zip codes are next to each other. They're here in Pittsburgh. Both zip codes have very different median home value, median household incomes, and racial distribution. So in zip code 15217, the median home value is around 250, when in Wilkinsburg, it is 88,000. Our median household income in Square Hill is around 62K, where in Wilkinsburg is around 37. The racial distribution, white 83% in Square Hill, Black 3.4%. It's very different from the zip code 15221, where you see white 46% and Black 48%. You can also see a difference in the distribution of children in between public school and private schools that you can see in Square Hill, almost half and half. When the Wilkinsburg zip code, you see most of the kids go to public school. So let's take a look at what the babies that were born in McGee will experience when they hit the age to go to school. These are two comparable schools. One is in Square Hill. The other one is in Wilkinsburg. The one in Square Hill, this school had, when we looked at the English language, arts, and literature standardized testing, the performance is around 74, 75%, and the Pennsylvania state average is 55. In math, it's 64%. The average in Pennsylvania is 38. So they're above the state average. The minority enrollment is 47% of the student body, where Blacks represent 20% and more races 10%. When we look at Wilkinsburg Public School District, the English language, art, and literature proficiency is 25%, which is below, well below the state average, and the math is 17.2%. So two schools, two different zip codes next to each other, very different performance. And I want you to notice that the minority enrollment in the school that we are presenting in 15221 is 96%, with Black students being 89, almost 90% of the student body. I also wanted to point out that there's also differences in access to pediatric primary care. Mom in zip code 15217 has many choices of where to go to get pediatric care for her baby. But mom in purple, if she wanted to stay in her local zip code, did not have as many options. When we look at UPMC Health Plan pediatric members' utilization trends in pediatrics ages 0 to 18 across different lines of business, which include Medicaid, CHIP, and commercial, we see a difference in utilization in emergency room and well child visits. If you follow the line that's bright blue, those are our Black members, pediatric members. And you can see that the emergency room utilization for our Black members is much higher than our Caucasian and Hispanic members. But when you look at the other chart to your right, is going to be the well child visits. And then you can see how that line flipped. Now, the well child visits trends are lower. So the children, our Black members, that our utilization of well child visits is much lower compared to other races. So again, Black pediatric health plan members have higher emergency room utilization and lower well child visits compared to Caucasian pediatric members. When we look at Children's Hospital avoidable ED utilization by zip code, we also start seeing some differences. The circles point out at the zip codes that I've been referring to, and you can see the contrast in color. The darker the purple, the higher the utilization. And you can see the trends, one side by all races and ethnicity, and the other one for Black members. Again, access to pediatric care by zip codes look different in Pittsburgh. And I quickly wanted to share with you that this is data points, but we also want to talk to the patients, to the families, to the members. And I want to highlight the amazing work that the Consumer Innovations team has been doing to better understand the end-to-end UPMC health plan experience. One of the things that we learned with this study, and we were asking families about their experience, is that we are one bleak purple family. When we're asking about UPMC health plan experience, they were telling us about their experience with their pediatrician. When we're asking questions about their clinical experience with the health plan, they were telling us how their experience was in the emergency room. So what we really learned from this experience is that parents do not make a difference between UPMC health plan, UPMC Children's, UPMC CCP, UPMC McGee. They see us all in purple, and we're one purple family. And they share with us that there's very barriers, and they were very frank about the aspects of pediatric barriers that they experience when they're seeking care for their children. I know we're running out of time, but I wanted to share with you a video. We asked them about the pediatric experience, and these two parents, one Caucasian, one Black, share their experience.
We've had that, oh, we think something's wrong. She looks to be in pain, something's not right. And we've had those experiences of like just going to an urgent care and getting care that way. When she broke her leg, I wasn't home. I came home, sort of assessed the situation, said, oh, we really need to find a place to go that has orthopedics that can do an x-ray. You're never kind of excited or feeling great about having to get medical care in a like emergent situation. Overall, I feel like her Medicaid has been like a lifesaver, like for her and our family, but it was a positive experience. It was, easy to hop on, see what the wait times are, and be able to like head over there and get care in a pretty easy, quick manner.
When he got hurt at school, three different
Yeah.
things. Broke his arm twice, and his shoulder before the arm was healed. It's like they did check his eyes to get his eyes checked, but I wanted to make sure that it wasn't a bone issue or, you know, something neurological going on. So I was very worried during that whole time because that is when the PCP had called CPS because of the breaks. And I came to them about getting help and wanting, you know, the scan done and the referral. I asked for all of this. It wasn't his regular doctor. They're a teaching hospital, so it's just rotating doctors all the time. His doctor was somewhere else. And because I wanted the referral, I wasn't going to wait for his doctor. Anybody could give us that referral. I just can't answer as a parent because I wasn't there because it happened at school. When they came out to the school, they talked to him and they closed it immediately. And they're like, no, you know, this is not neglect. This is not any of these things. So to have your focus even briefly taken off your child because of that situation, I was very upset about that.
I know we're running out of time, so I just wanted to share with you that, you know, by asking families, they'll tell us their stories, and there are definitely disparities in the treatment experiences of patients. Oops, there we go. Let me see if I could. I'm going to wrap it up with the case I mentioned earlier. This is a 30-month-old child that I saw in clinic, and I asked mom, you know, why, you know, how can we help you? I saw that your child was in the emergency room 6 times in the last 12 months. And she shared with me, well, if you look carefully at the records, I haven't been in the emergency room for the last 3 months. And I did look, I'm like, oh yeah, what happened? What changed? And she said that we moved. Our house was infested with cockroaches. And it was not until I moved to a new home that my child asthma got better. She also shared that she was in the emergency room 6 times. And nobody asked her about her home conditions. She also shared how scared she was to share that with somebody because she did not want to lose her child. So when we think about and encounter patients, it's really important that we have the whole picture and that we don't make assumptions and that we create a space that's safe for them to share their stories and not feel judged. If I want to leave with one message today is that we all have a responsibility and we're all part of the solution. I work for UPMC Health Plan and also for Children's, and I have to say that both organizations are highly engaged and devoted in addressing health equity. We have much opportunity. There's one thing I really want you to walk out of here today is that without your contribution and your passion and your engagement, we won't be able to find a solution, and we need you. Multiple strategies are required to reduce, if not eliminate, health disparities. And I do believe that we can achieve this together. Thank you.